Well, hello everyone. um, I'll be going through today, and I'm not going to be keeping an eye out on the chat because it's in a separate window for me. Pardon me. And then I'm going to find myself sort of, instead of teaching, I'm going to find myself going through the chat bit by bit. But as we go, I'll check in occasionally, and we'll have time at the end for some questions. I'm going to do my best so that we can address them. The good news is, even if for some reason we don't have time this evening, or you need to jump off, or you're otherwise watching a recorded thing and can't access it live right now, my name is Rami Duckworth. I'm an easy Google away, and any Twitter handle or email address or anything like that that you find, if you'd like to ask me a question that way, you are certainly welcome to. That's why we're here. That's why we want to teach about this. And a big part of this topic is exactly what it says on the label, what they didn't tell you about anaphylaxis. Now, I've been in EMS since the late 80s, and I've been a paramedic for quite some time. And I'm always amazed about information that I come across that I feel like, wow, why wasn't I taught that in EMT class? Why didn't I learn that at first as a paramedic? Why am I just learning about this now? And sometimes these are things that I find out we didn't know back in the day, or we had a different perspective. Nowadays, with electronic medical records and a lot of our ability to analyze data and collect data, and we're really able to figure things out that we just weren't able to back in the day. But other things are just things that, by gosh, we're not quite sure how we got steered in that direction, but we know a little bit better now, and we want to share it, and that's why we're here. Now, one of the things I'll let you know is that I don't have any conflicts of interest. I'm going to be talking a lot about administering medications and the right things to do, but I'm not being sponsored by anybody for this. This is all just for us to be able to share this information and kind of figure things out. And what I want to be able to do is answer some questions for you, including the ones that you see right here, like, what is anaphylaxis? What do we give for it in terms of overall medications as EMTs or paramedics? When do we give it? What kind of problems can we run into? And what can we do better? And what I'd like to do is start with an overview to get us sort of the lay of the land for anaphylaxis, as well as set us up for some of the right things that we're doing and some new projects and initiatives that are coming out. So let's begin with that.
Every year, up to 2,000 people in the U.S. and Canada die from anaphylaxis, a serious allergic reaction. The most common causes are allergies to peanuts, insect bites, and seafood. But not all anaphylactic reactions are severe. They can be mild, with subtler symptoms. And most people don't know that if you've had a mild reaction in the past, you're at risk of having a life-threatening one in the future. More from Mayo Clinic on a new anaphylaxis awareness campaign. John Lindine's reaction came on fast.
I started to feel a little dizzy. It was becoming very, very difficult for me to breathe.
John remembers reaching for the phone to call for help. When help arrived, he was in big trouble.
I was collapsed and unconscious on my kitchen floor, having turned a shade of blue.
John's episode was likely triggered by peanuts. He's been allergic since childhood, but symptoms had always been mild: nausea, hives, and flushing.
Those who've had a mild allergic reaction to a food substance or an insect sting at one point can have an anaphylactic reaction unpredictably in the future.
Dr. Wyatt Decker says anaphylaxis happens when your immune system identifies a substance, such as peanuts, as foreign. This triggers cells called mast cells to release chemicals that cause many symptoms, including dilated blood vessels, low blood pressure, flushing, constricted airways, intestinal problems, and even death. But an injection of epinephrine from an auto-injector can reverse symptoms and save your life.
Pull off the cap and you hold it to your thigh and you inject it, and then you hold it in there for 10 seconds.
Dr. Ronna Campbell and Dr. Decker have teamed up with other health organizations to teach people about anaphylaxis. It's called the Be Safe campaign. S means seek support, call 911. A stands for allergen, try to identify what caused your reaction. F is for follow-up, see your doctor afterwards, and E is for epinephrine, the medication John carries with him in case a severe reaction happens again. Dr. Decker says if you have an anaphylactic reaction, it is vitally important to seek emergency medical care. That's because sometimes symptoms can get worse or even recur within 24 to 48 hours. It's also important to talk to your doctor after an allergic reaction to see if you should be carrying an epinephrine auto-injector. The team of experts spearheading this campaign includes members of the American College of Emergency Physicians and the American College of Allergy, Asthma, and Immunology.
And that gives us kind of an overview of anaphylaxis as a whole, as well as some of the initiatives that have come out over the past 5 years or so to really help focus and bring healthcare providers of all levels together on what we can and should be doing for patients suffering from anaphylaxis. So moving on to the direct definition of anaphylaxis. Anaphylaxis is a serious, life-threatening, systemic hypersensitivity reaction, and it's everything that says right there on the label. Again, serious and life-threatening, if nothing else, it's redundant, but because when we say serious, healthcare providers all get a different idea of what it means to be serious. Full-on life-threatening is what we're talking about here. Systemic, meaning it's throughout the entire body, although you may not see it manifest itself in all body systems, it's happening throughout the body. And it's a hypersensitivity reaction. Now, one of the things we mentioned here right up front is to help focus us, and I know you know the answer to the questions I'm about to ask you, but I want to use them to focus the way we're thinking about anaphylaxis. So a lot of what we're going to be talking about tonight is going to be bits of information that you likely already know about. But I want to turn it on its head. I want to shine maybe a different light on it, look at it in a little bit of a different angle so that we can improve our assessment and care for patients with anaphylaxis. So the first thing is, if someone's allergic, not just allergic, if someone has had an anaphylactic reaction to, say, a bee sting, do they have to be stung by 100 bees before they get anaphylaxis? If someone has had a reaction to peanuts, do they have to eat a whole 5-gallon tub of peanut butter before they have a reaction? And the answer is right there in the chat. Right? No, we know that, but I want us to keep that top of mind as we're thinking about this. So it's not that the body is overwhelmed by like the amount. When someone gets anaphylaxis from a Hymenoptera sting, from a bee sting, that's not their body reacting to the bee toxin, or at least I should say, it's not the body being poisoned by all the bee venom. It's the body has a normal reaction to say, hey, this is something that's not good, and we want to compartmentalize it, and this might hurt the body. But what happens is this chain reaction of chemicals in this body, this chain reaction of this allergic response, which can be uncomfortable, but is good, it's supposed to contain something that might be harmful. It gets out of control. It's normally supposed to be self-limited. It's supposed to stop at some point and keep, again, compartmentalized. But in this case, it just takes this one trigger, whether it's a single bee sting or a whiff of peanut butter or whatever it happens to be, and the body doesn't stop reacting. And that's why it's this systemic hypersensitivity reaction. And the key is we're going to define exactly patient criteria for anaphylaxis and the way we have to stay in front of anaphylaxis. We don't want to be reactive. The whole reason that we're having this conversation right now is healthcare providers across the board, from physicians to nurses and family doctors and ER doctors and EMRs and EMTs and first responders and paramedics, it doesn't matter. As a whole group, we tend to be very reactive when it comes to anaphylaxis in virtually all of the research, all of it, every study ever, we're reactive. And we want to stay ahead of it because while an anaphylactic reaction may not look terrible right away. As it says right here on the screen, it could be unpredictable and rapidly fatal. When we're talking about statistics, I don't want to get too bogged down in numbers. There's widely variable statistics reported all over the place. But the big numbers that we need to pay attention to, the fact that these numbers are rising, and there's discussion as to whether it's just we're more aware of anaphylaxis, or maybe more people are becoming sensitized to things and having reactions to things that people didn't have reactions to before. It seems like there's a combination of it, but somewhere between 1.5% and 5% of all citizens in the United States have had anaphylaxis. So that's pretty big numbers. When you're not talking allergic reaction, you're talking anaphylaxis. Now, we know the top part, but I want to talk about the other three that you see right here. Anaphylaxis usually happens within 20 minutes, usually, but it can be up to 4 to 8 hours later from the exposure. So in other words, if someone is allergic to shellfish and maybe they had some shellfish, or they had something that was cooked with or near shellfish, all right, and it's been about an hour, I've heard EMS providers say, well, it's been an hour, it's been a couple of hours. You would, if it was going to be anaphylactic, you would have had it by now. That is not true. It is 100% not true. Now, typically, yeah, we can have it within, patients typically have that reaction within 20 minutes. Absolutely true. But we can't flip that around and say, well, if it isn't 20 minutes, then it's not anaphylaxis, because that's not the way signs and symptoms work. But I've heard it many times, and I understand how tempting it can be, because what you want to say is, well, usually anaphylaxis usually happens within 20 minutes. But we have to be careful about the way we communicate with this to patients and their families. And we have to be careful about the way we think about it, because not only can anaphylaxis happen 4 to 8 hours after the initial exposure, it can be biphasic, which means it can resolve with epinephrine and other medications, and then it can come back again. The good news with the biphasic anaphylactic reactions is they tend not to be life-threatening the second time around, but they can happen and they still need to be managed. Also, anaphylaxis can be refractory, which means it continues past that initial management. Now, epi is what we want to give. Anaphylaxis treatment, the number one treatment is epinephrine, and we're going to explain why epinephrine is practically custom built to beat anaphylaxis in every way. But the important thing to know is there are times when epinephrine won't work for a variety of reasons. Now, I got to give you a warning. We're going to do a little bit of pathophysiology of anaphylaxis, and there's going to be a bunch of stuff on the screen, but I can promise you, please don't get overwhelmed. I want to show you the relationship between the different things on the screen. You don't have to memorize all the things on the screen. Just want to show you the relationship and show you the just examples of different things. Now, number one, when we think of anaphylaxis, we tend to think of what they call immunologic anaphylaxis. It's typically mediated by immunoglobulin E, technically speaking. And I want to take a minute for you to take a look down at the bottom of the screen. You may have already noticed this as we've gone along, but I've got citations and references as we go, because I don't want you to think I'm just sort of pulling this information out of thin air. And if you want more information, I want you to have it. This is like a train the trainer kind of a thing. So immunologic anaphylaxis, it's kind of what you would think of as classic anaphylaxis, often triggered by different foods, like we talked about, shellfish, nuts, bee venoms, latex, some drugs like antibiotics. And again, it's primarily mediated by immunoglobulin B, and it's directly related to the part of the immune system called the B cells. Now, you don't have to memorize all of this. If you already know a little bit about the pathophysiology, I want to give you a little more details. But what's important is the empty part of the screen that's going to fill up so you can see the relationship, because there are types of anaphylaxis that are non-immunoglobulin E mediated. They're mediated through different parts of the immune system. And these can be medications that trigger anaphylaxis, like dextran and things like that. Now, you may think, okay, well, this is all well and good, but I'm not working in a hospital. I'm not worried about triggering anaphylaxis with dextran. That's like stuff people in the hospital are going to get, worried about. And I'm not going to be able to tell whether it's immunoglobulin E or non-immune. That's fine. That's the whole point. You're getting it. That's exactly the point I want to make. When we look at this, there's classic anaphylaxis, but it almost doesn't matter. What we need to take away is there are different pathways, including contact dermatitis triggered anaphylaxis, which is mediated not by B cells, but by T cells and sometimes B cells with immunoglobulin M. So we're looking at all this. The immune system starts to go crazy, right? It's triggered within chemicals within the immune system, but they're not all exactly the same classic way we think of anaphylaxis, but it's all anaphylaxis, okay? So people can have anaphylactic reactions to things beyond peanuts and shellfish and bee stings and all of the classic stuff that we tend to think of. That's the key here, because there's this whole other category. Now, there's non-immunologic, what we used to call anaphylactoid reactions. And they would say, like somebody writing a textbook would say, you know what, if it's immunoglobulin, it's anaphylaxis, because anaphylaxis is immunologic. And then somebody said, well, yeah, but people have the same reaction, but not through the immune system, but it's the same reaction. So what do we call those? Oh, anaphylactoid. Don't worry about that. We don't even do that anymore. The only reason I'm still using those terms is some of us who've been doing it for a while may have heard of anaphylactic or anaphylactoid reactions, but you see that they're all lined up together. Now I want to explain my first contact with this ever is I'm a scuba diver, and I used to go diving with this lady who said, oh, I'm allergic to cold water. And I said, no, you're not. And she said, yeah, no, I'm allergic to cold water. I'm like, no, you don't like diving in cold water. You like diving in tropical water. I love diving in tropical water, but you're not like, look, I'm a paramedic. You're not allergic to cold water. It turns out she's allergic to cold water, and I saw it happen in front of me. And that was one of the reasons that I wanted to look more into this. And it turns out, yes, you could be allergic to exercise. Now, I'm not a doctor, so don't expect me to write a note that says, yes, I can't exercise. I'm sorry, I'm allergic. But the point is that just about any kind of trigger can cause an anaphylactic reaction. Now, because we call them all anaphylactic reaction. And they could be physical, like responses to exercise, cold water, cold air. They could be triggered by toxins like scromboid fish poisoning. It's got very, very high histamine levels. So basically the toxin itself is, instead of the immune system dumping a lot of histamine into the body, you could eat something that dumps a lot of histamine into the body. And they're pharmacologic, where the medication doesn't trigger an immune response that causes anaphylaxis. These are NSAIDs, opioids, radiocontrast dye that directly cause the anaphylactic reaction. It's kind of crazy, and you can sort of almost split hairs with what is what. But here's where it all comes together, and this is important. It all comes together because all of these, the choke point is they all trigger mast cells and basophils, and sometimes we have something called idiopathic anaphylaxis, which means we literally have no idea what caused it. It doesn't matter. So the next step, no matter where it comes from, if it's a bee sting or they're allergic to cold water or they had contact dermatitis or they had radiocontrast dye, it triggers mast cells, which are filled with, and basophils, which are filled with all different chemical mediators that make things start to happen in the body. So it all comes down to these components of the immune system. Now they trigger all of these kinds of chemicals and more. And the big ones will start from going left to right, and you don't need to memorize these. But going from left to right are kind of the big ones that we pay attention to. Now everybody's heard of histamine. Mast cells degranulate, they basically break apart, and they release tons of histamine into the body. And histamine does things like cause congestion and all the things you take an antihistamine for. That's what histamine does. Histamine lowers blood pressure, does a lot of things, but there's also tryptase, chymase, and all of these other different chemicals. again, you don't have to memorize them all. The point is mast cells and basophils release histamine, which we normally think of, but they release a lot of different chemicals, tons of different chemicals that do all sorts of different things. So while we typically picture the physical reaction that a patient gets because of the histamine that we see working, there are a lot of other chemicals at work in the body, often out of control, doing damage. And that's what produces this difference that we're talking about. Say, difference between an allergy and anaphylaxis is an allergy, these chemicals fire off and then go away. It's like fireworks in the sky that go off, and it's bright and beautiful, and they fire all over the place, and then they sparkle down, and then they're done. Whereas anaphylaxis strikes these pathway amplifiers, okay? The body just reacts a little bit differently. And it's like dropping a ping pong ball on all of these mouse traps. Once it starts triggering one chemical, those chemicals trigger more chemicals, and those chemicals trigger release of more chemicals, and it's one after the other, after the other, after the other. And that produces all of those responses that we're familiar with. And again, you don't have to read all the stuff on the bottom. If you can, that's great, but you know, skin reactions, there's itching, flushing, hives, and edema. The respiratory response, cough, dyspnea, hoarseness, stridor, wheezing. The GI response, nausea, vomiting, diarrhea, and abdominal pain. Cardiovascular, dizziness, hypotension, shock, and central nervous system disturbances, including headache. Like, these are all the things that we see that start to get out of control because of all of these chemicals that release and trigger more chemicals and trigger more chemicals and trigger more chemicals out of control. That's anaphylaxis. The good news is epi blocks right there at mast cells and basophils. Now, we normally think of epi for the cardiovascular effects and the respiratory effects that it does, which are great, which are like built to counteract. But what we don't think of is that epinephrine also helps block those reactions, limiting their re-release and triggering of more reactions. It basically stops that domino effect, or helps stop that domino effect. And I get so many people who are like, well, I give the epi to resolve the symptoms, and I give I'm going to say it once, but I'm going to tell you now, Benadryl, not for anaphylaxis, but we'll get into that more later. I've seen people say, like, oh, I give the epi to resolve the symptoms, and then the Benadryl is to stop the reactions. No, the epi is to stop the reactions. Why do we give it? Well, it's an alpha-1 agonist, all right? It prevents and relieves hypotension, shock, and edema and swelling, right? And then we've got our beta effects, and we always remember beta makes bigger, right? Beta is bigger. Beta 1, we got one heart, beta makes bigger. So beta boosts the heart and increases the rate and force of cardiac contractions. Beta makes bigger. Beta 2, you got two lungs. Beta helps bronchodilation. Beta makes bigger. It opens up the lungs with beta 2, and beta 2 also decreases the mediator release and helps stop that chain reaction. That's critical, and that's why epi works so well. But why do some people hesitate to give epi when they should? Well, they make all sorts of kind of excuses, and I understand it. Like, I've been there myself. You're like, previous reactions weren't so bad. The patient didn't use their EpiPen, so I'm hesitant to use or administer epi. The patient doesn't think it's needed, so I'm not going to worry about it. Symptoms seem like they're mild. There wasn't a known exposure to an anaphylaxis trigger, or they think there are contraindications like pregnancy, old age, or cardiovascular disease. None of which, by the way, are contraindications for giving epi for anaphylaxis. But again, I've been there. I've heard people say this, and I want to clear up these misconceptions. That's why we're here, right? So we should still administer epi. The thing is, we run into issues with this sometimes, like I say. So patients who have anaphylaxis, okay, 573 consecutive patients with anaphylaxis, and less than 60% of them got epi. Only 4 of 316 patients developed any adverse events, any kind of a problem with epi. So it's 1%. And there were no overdoses or other significant problems with IM injection. Some people give the epi IV and they ran into higher problems. Even if you could start an IV, you're a medic, that's fine. We still want to give epi IM, not sub-Q, not IV, IM. And you don't have to just trust me on this. This is from the American College of Emergency Physicians. And I don't like to put up walls of text when I'm doing presentations, but here it is, man. Epinephrine in the correct dose for anaphylaxis doesn't cause coronary ischemia. There are no absolute contraindications to epinephrine in severe anaphylaxis. In the World Allergy Organization, the specialists in anaphylaxis, failure to use epi or to use it promptly is an important factor in avoidable factor in fatal reactions. Avoidable is that key word. We don't want to fail to use epi or fail to use it fast enough, because that's an avoidable issue in fatal anaphylaxis. We don't want to have missed the opportunity to help somebody who's in front of us because we didn't think the anaphylaxis was that bad at that point, and we waited and were reactive until the anaphylaxis was so obvious that the epinephrine didn't do as well. So when do we administer epinephrine? And I know I can't hear you, but I want you thinking it. You could be thinking it, you could say it out loud, you could type it. When do we administer epi for anaphylaxis? Immediately. Sooner is better than later. Later is often fatal. So we got to get in there. The number one cause of death in anaphylaxis. The number one cause of death in anaphylaxis. The number one cause of death in anaphylaxis is failure to give epi in a timely manner or in the correct location or the correct dose. So we're going to clear all of that stuff up. So, what kind of signs and symptoms do we normally see that tell us, hey, anaphylaxis, right? It's urticaria and angioedema. So the skin cells, or skin signs and symptoms, I should say, are most, but that still means even if 85 to 90% have them, that means more than 1 in 10 patients having anaphylaxis don't get hives or skin rash, okay? More than 1 in 10 have anaphylaxis with no skin signs. And that's important because one of the biggest myths I find that we have to keep up with anaphylaxis is that you can't like flip those numbers. You can't say, well, you don't have any hives, so it's not anaphylaxis. I've seen it happen. I've seen on more than one occasion, EMTs and paramedics telling patients and family members and bystanders and caregivers and parents, well, there's no hives, so I know that they're not feeling well, but it's something we know it's not anaphylaxis because they don't have the hives. And as we go down, we look at some of the other classic signs and symptoms, right? Dyspnea and wheezing and upper airway angioedema. The angioedema is that severe tissue swelling. And the cardiovascular, the hypotension, dizziness, or syncope, somebody feeling like they're going to pass out, going into shock. But don't forget too, nausea, vomiting, diarrhea, or abdominal cramping. That's 1/4 to 1/3 of people with anaphylaxis have these GI symptoms as the body tries to get rid of the trigger. So patients may present with unexplained urticaria. That may be sort of how we get drawn into this in the first place. Difficulty breathing may not be even a primary complaint. They may have no cardiovascular symptoms, but they'll still benefit from epinephrine administration. Now, when we're looking at this patient presentation, as we say, these inflammatory mediators, right, these chemicals in the immune system that's tied to the inflammatory response, important to know, the immune system, a big part of the immune system is the inflammatory response. So when you get congested, not just the mucus, but like the swelling in your sinuses and things like that, that's part of the inflammatory response. What that is the body's immune system saying, hey, we found something that the immune system has to attack, has to fight. It looks like it doesn't belong in the body. So we're going to swell up, but really what we're doing is we're opening up the circulatory highway to the area that we think has a problem. And we're going to open up the capillaries. So any parts of the immune system that have to fight this foreign thing can get down the enlarged arteries and get past the capillaries into that part of the body to fight whatever's being triggered. Okay, so that's the inflammatory mediators start to cause this tissue swelling. Now, again, in an allergic reaction, it's uncomfortable, but it's good. That's how the body, it's how the immune system works. It's how the inflammatory response is doing what it's supposed to get factors there to clean up, clear up, and fight whatever is the trigger. In anaphylaxis, these mediators that are supposed to be limited start causing swelling like crazy, or swelling in parts of the body that shouldn't even be involved. Other upper airway symptoms, we can see them, you can read them: sneezing, runny nose, sore throat, etc. A sensation that the throat is closing or tightening up. Now that's all the upper airway. In the lower airway, we get that cough, wheezing, mucus plugging, even pulmonary edema, hyperinflation as air starts to get trapped in the lungs, and trouble breathing as the patient goes. So the angioedema, those are things that we're not going to see from the outside. Now, when we talk about the cardiovascular system, again, for the physiology people, I want you to know exactly where it's coming from. For the people who are not as into physiology, that's okay. You don't have to memorize this. But it's activation of the ATP, adenosine triphosphate, the ATP sensitive potassium channels in the plasma membrane of the vascular smooth muscle. They wind up causing the dilation, the vasodilation, and the little sphincters in the capillaries to open up to leak fluid out of the capillaries. There's also activation of the inducible form of nitric oxide. Now, what does that do? Nitric oxide causes more vasodilation. In addition to that, you have a vasopressin hormone. This is an internal vasopressor, okay? It helps boost your blood pressure. When a patient has anaphylaxis triggered, vasopressin hormone that normally helps retain urine and boost blood pressure, there's not enough of it circulating. It gets burned up, if you will. So these are all reasons that sometimes with anaphylaxis, the blood pressure goes down. Doesn't mean this is the primary thing that's happening, but the problem with anaphylaxis is it's sort of like a one-armed bandit, right? Like they pull the anaphylaxis lever and the wheels spin and you never quite know what you're going to get. So we can't always look for one type of presentation. There's that increased permeability and capillary leak like we talked about. Well, that's distributive shock. Volume shift, the blood volume can then move out of the vascular space. Up to 35% of it can flood out, and that produces hypovolemic shock. And these inflammatory mediators that are doing all of this work can also depress your heart's ability to beat hard and fast enough, effectively resulting in cardiogenic shock. So I'm telling you this is not going to be a test question about what different kinds of shock. This is just to help us sort of wrap our head around the fact that when we say anaphylactic shock, you're actually talking about often a number of different types of cardiovascular shock issues that could be happening all at the same time. And here's the problem, is it may not be obvious to you initially, but if we wait until this stuff is happening so that there's enough vasodilation and enough capillary leak that fluid is dumping out, that now all of a sudden we really see the pulse rate going up and maybe even the blood pressure or mean arterial pressure going down. Well, at that point, we've waited too long. The epi might be able to help, but we've let the anaphylaxis get so much of a headway that now we're really pushing a big boulder uphill. We want to get it early when all of this stuff isn't as clear and obvious to us. So some of the stuff that we already talked about too, you also can have this pulmonary vasospasm. So the pulmonary artery and vein can wind up squeezing down. It decreases left ventricular preload, so the blood coming back to the left ventricle can't get into the left ventricle can't fill up. So not only does that decrease the cardiac output, all right, left ventricle, that's your main pump of the 4 chambers of the heart that pumps the blood through the aorta out to the rest of the body. If that's not filling up, then it can't push as much blood out. If that's happening and say the patient is laying down, right, they're already not getting enough blood filling up into their left ventricle because the lungs, the blood vessels through the lungs are squeezed down. Now this patient doesn't have a full ventricle, they sit up, and that completely decreases their ability to get blood back into the heart, and it causes what they call an empty ventricle. So now the left ventricle is pumping, but it's empty, it's got nothing in it. The patient basically passes out at that point. Now we've got GI issues as well, including nausea, vomiting, and cramping. Now we need to keep these in mind, not just because the patient's going to be uncomfortable, which they may be, but I see so many times people look for those skin signs and they go, well, they don't have the skin signs that I'm expecting to see in anaphylaxis, so I don't think it is anaphylaxis. But then they're not asking or looking for signs for like nausea, vomiting, cramping, diarrhea, the GI symptoms that are supposed to go with this. And they're not even asking. Well, the patient may not be, like, they're waiting for you to ask questions. Don't always expect you're going to show up, and because the patient complained about 1 or 2 things, they're going to tell you everything that's bothering them. Get it? Sometimes we have patients and you can't get them to stop telling you what's bothering them. I get it. But we need to make sure that we're asking all of these questions. That's why I'm putting up the GI symptoms. Like, nobody's probably going to die from some abdominal cramping that goes along with this. But, you know, if there are still important symptoms that you're going to see with, you may see with anaphylaxis that leads to our diagnosis of anaphylaxis and leads to us giving epi. We could also get some direct CNS or central nervous system, some direct brain issues because of anaphylaxis. Not just dizziness, syncope, headache, but this feeling of doom and anxiety. So we've talked a lot about a bunch of signs and symptoms, but here's the deal. The World Allergy Organization, and I can tell you virtually every clinical organization, including the American College of Emergency Physicians, all agrees to this criteria for anaphylaxis. And I found it's not in a lot of textbooks, even though it's been around for a little bit of a while. And it's pretty good, man. It's sensitivity of 96.7%, specificity of 82%. It's 3 easy checks. Here's the deal, and I don't want to just tell you, I want to show you. Any of the following 3 scenarios is anaphylaxis. And I'm going to start with an easy one, but they're not all this clear. Okay, it's almost 9 o'clock at night. You're dispatched to 1022 Chester Street, a restaurant for a 43-year-old female with multiple complaints. This is what she looks like when you get there. All right, so she's got some skin redness, and she's complaining when you arrive. You introduce yourself, she's complaining of a swollen tongue.
No, she's had some salmon, she's had some camembert. Have you touched anything, or?
I haven't my tongue is
Right. Okay.
All right, okay. She's got a heart rate of 150, okay.
All right, so you caught that. She's trying to explain that her tongue is swollen and her heart rate is 150, okay? And they're trying to identify that she was exposed to a known trigger. So here's the thing. The first criteria, if you run into this kind of a scenario, it doesn't have to be as severe as you just saw, but we've got exposure to a known trigger and a sudden reduced blood pressure or signs of organ dysfunction. Now, organ dysfunction sounds a little vague, but if she's got that lady's got a heart rate of 150 supporting her blood pressure, that's a sign of organ dysfunction. A lot of people get confused like that. So we knew she was exposed to a trigger. Her pulse rate is super, super high. And you get the added bonus of her tongue is swelling up. That's not a bad allergic reaction. That is anaphylaxis. And what drug does anaphylaxis get? I'll wait until somebody types it in for me. What drug do we give for anaphylaxis in this situation? We're giving it, and we're giving it right now. Epi, 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 epi. I love it. We're on it. We're on it. You're right. And here's what they did.
Right, Amy, so we'll go 0.5 milligram of adrenaline, salbutamol, please, eventually some hydrocortisone as well, all right?
Tammy will need repeated doses of adrenaline to help her body fight the reaction.
So they said salbutamol in the UK, just like they say aluminium. That's albuterol. They call it salbutamol. Now they're looking down the road to give some corticosteroids. We'll talk about that, but the important thing is it's epi now. And I don't mind the breathing treatment to go along with it, because now, as the case has progressed, she's starting to talk about difficulty breathing. So I like the fact that they're thinking about a bunch of things, but epi is key. And it does not matter whether you're a 30-year emergency department physician or a 10-year paramedic, or the ink is still wet on your EMR card. It doesn't matter. It's epi. And that's what they hit her with. And this is how fast they were able to turn it around, although your mileage may vary.
We got to Amy and the doctor actually said, well, there's nothing I can do now, just monitor her because you guys have done it all, which is really satisfying.
Some years ago, when paramedics were merely just first aiders or advanced first aiders, wouldn't have been able to treat something like this. So knowing that we have the training and the skills to treat conditions like this now, it's very reassuring for me and other people.
I've never had an allergic reaction to anything before. It was quite scary. I realised how serious it was and how quickly I needed to get help.
And that's the deal. Now, I wanted to start you off with an easy one. So this one, she also had the tongue swelling. Okay, so we get there. But the key is known exposure and cardiovascular. So like if pulse rate is up and blood pressure is already down, or any sign of organ dysfunction, we'll get into that a little bit more later. Those signs and symptoms of organ dysfunction, we're on it. So known trigger, organ dysfunction, that's the easy one. We're going to get into a little bit more subtle as we go. Okay. It's the next day. First thing in the morning, you get your coffee and you're dispatched to 38B Grove Street, the pediatrician's office. That's where the pediatrician's office is in my town. And you get a 30-month-old female, has a vomiting and a rash after eating cashews. So you're going there and meh, but here's the thing. Here's what she looks like. Okay. Vomiting and a rash after eating cashews. That's the second possibility for us, okay? Likely exposure to an allergen or trigger. What was she eating? She was eating nuts. Okay. A lot of people were, it's a common source for anaphylaxis, so okay. And then plus basically any two signs or symptoms. Now, I listed them out for you and I color-coded them, but anything that falls into these categories. So sudden reduced blood pressure or organ dysfunction. And again, a very high pulse rate to keep their blood pressure up is part of it. Or altered mental status is organ dysfunction. Low urine output is organ dysfunction because if the body's going into shock, it's not providing the kidneys with enough blood pressure to produce urine. So any of those are organ dysfunction. I'm just giving you a couple of other examples. I don't want to make it too complicated. Okay, so a likely exposure to an allergen like those cashews and sudden reduced blood pressure, organ dysfunction. Now, did she have the organ dysfunction? No. Sudden respiratory signs and symptoms. No, she didn't have that. Sudden skin or mucosal tissue. Yes, she did have that. She did have her rash and sudden GI symptoms and signs. Well, yeah. So she had some cashews. She had a rash all of a sudden and GI signs and symptoms. Here's the thing. That is anaphylaxis. It's more subtle. It is anaphylaxis. It's not guaranteed that it's going to kill this little girl, but it is not the best thing that we could do. Honestly, I'll speak plainly. It's irresponsible for us to let that go until it gets to that point. So here's how she worked out.
Sweetheart. So we're going to do a real brief, geez, I love it. So we're going to just do a real short video here on anaphylaxis. This young lady presented here after ingesting some cashews and had an episode of vomiting, and then broke out in a rash, and also, well, before that was actually doing some wheezing and having some airway complaints. So I was having a conversation with her mother, and we discussed what anaphylaxis is. Anaphylaxis is basically two body systems that are involved in an allergic reaction.
So she vomited first.
Vomited first.
And then she had wheezing.
And you took her to put her in the bathtub.
Because she vomited.
And you know that while in the bathtub she was wheezing, making loud noise, breathing noises. And then thirdly, you noticed the rash. Okay. So as we talked about, two body systems involved, that's your diagnosis of anaphylaxis. Life-threatening, serious, something that needs to be treated right away. You very wisely called EMS, and EMS treated her, and they treated her with some IM epinephrine. So a lot of people still think it's sub-Q, but it's intramuscular. It's usually the anterior lateral thigh.
She got it in the thigh.
Did they get it in the thigh?
Right there.
All right. There we
See
go.
the spot?
Okay. And they gave her some Benadryl. She was watched here. By the time she arrived, my understanding was that her rash had markedly improved. I was not here when she first got here. Now we've watched her for a couple hours, and all of a sudden, Mom said her rash is back. And sure enough, it's on her face. We'll get a close up on her face here. And her ears are red. She's scratching. Cheese. And then let's see if her tummy. Anything on her tummy?
Tummy.
Yep. Breaking out on her tummy and on her back too.
Look at stickers.
All right, let's see your back. So, all right. So we're giving her.
She's hot to the touch.
We're gonna actually end up giving her another dose of Benadryl. She has had some steroids. She has some Decadron. Is that right? And so we're going to give her an H2 blocker, which will be famotidine. And we give her, like I said, we're going to give her some more Benadryl, famotidine, and then another IM epinephrine of 0.01 ml per kilogram. And she weighs about 11 kilograms. So it's going to be about 0.1 ml or 0.1 milligrams. So, all right. Well, hey, these videos end up on YouTube. You're okay with that? That's fine. Okay. You got to sound more enthusiastic than that.
That's fine, yeah.
Okay, good.
So I want you to hear it from not just from me. That was a life-threatening situation. It was going to progress to life-threatening situation and even wound up coming back. And even though they gave additional medications, they still come back to the epinephrine because that's the key. All right, your last case study. It's 5 o'clock in the morning. You got a 51-year-old female with difficulty in breathing. Now, the video's not the absolute best, but I want you to look at the top of her chest there and see the skin signs right there. Here she is. All right. So what do we have here? You can hear it, right? You can hear the wheezing. And again, I know the video is not the best, but we got it paused right there. You can see the hives on the top of her chest there as she's moving around. It's difficult to see the redness, but you can see sort of the lumps. Those are the hives right there. So what do we have in this case? Sudden skin involvement and either the cardiovascular or the respiratory. Sudden skin, like I'm not even worried about what caused it. I'm not worried about it. It doesn't matter. It's anaphylaxis, sudden skin issue, and in this case, pretty severe wheezing. Now, again, you can hear that, and people will be like, well, you know, could it be some different? It's anaphylaxis. We diagnose it as anaphylaxis, and what are we given for anaphylaxis? We're given epi, and I want you to see it work live. Oops, sorry. That's how fast it works. Now, later on, this lady did murder her boyfriend for filming the whole thing instead of using the EpiPen, but we can't get into that now. That's all right. Bringing it back. Bottom line number one, node exposure plus cardiovascular, that's anaphylaxis. And for anaphylaxis, we give epi. Number two, suspected exposure plus symptoms, anaphylaxis, we give epi. Sudden skin signs and either respiratory or cardiovascular, we're not asking a ton of questions before we give the epi for anaphylaxis. Listen, we're still asking questions, but what we need to do is stay ahead of anaphylaxis with epi. So I'm hitting epi pretty hard, right? Here's the deal. Do we give epi when we should? Well, we know that rapid administration decreases risk of hospitalization. Delayed administration increases the risk of biphasic reaction or death. But generally, less than half, and sometimes only 1 in 5 cases of anaphylaxis get epi at any point. We had one study that showed fatal cases of anaphylaxis received epi before they were actually in cardiac arrest and getting cardiac arrest epi in only 14% of cases. People hold off on giving epi. So I'm going to present you with a case, right? 32-year-old patient, hypotensive with wheezing, tachycardia, tingling in his throat and hands, and hives on his chest. This was the exact case given to healthcare providers. Less than half said that epi was the initial drug for this classic case of hypotensive wheezing and tachycardia with tingling in the throat and hands and hives on the chest. Less than half said epi was the initial drug. Almost the same number of people started with Benadryl, which is a terrible drug, as started with epi. More people gave epi sub-Q than in IM, which means that it was delayed in its working. We're not giving it shallow sub-Q, we're giving it IM. For those of you who are wondering, EpiPens or any of the epi auto injectors give it IM. Almost 2% gave epi IV, which we don't want to do that for a variety of different reasons, but it usually winds up with dosing errors. So that was healthcare providers across the board. What about EMS specifically? Well, they did a study in Broward County, 92 patients with an allergic reaction. 52 of them had anaphylaxis, okay? Only 15% of those patients were given epi by medics. Every single one of them should have been given epi, even the patients who already got epi, absolutely 100%. It's what's in the textbooks. It's what the World Allergy Organization says. It's what American College of Emergency Physicians says. 50% were given oxygen for reasons, I guess. They were given everything else, IV fluid, steroids, albuterol, and the dreaded Benadryl. 81% of them were given Benadryl, but only 15% given epi. Here's the thing, man. Don't worry about the Benadryl. It's a terrible drug. It's an antihistamine. It's probably the worst antihistamine. It's a terrible H1 blocker with a ton of side effects. It's not even, if that's what you want to give for it, Benadryl's an awful choice. But even if that's the only antihistamine that you have, that's way down the line. It's epi, epi, epi. But you know what? Here's the thing. That's these crazy East Coast, these Florida medics, right? Let's go to California, where everybody's a medic and they got it going on. Alameda and Contra Costa County, okay? Just north of San Francisco there. 205 pediatric patients, almost 100 with anaphylaxis. Here, it's even worse. Only 12% were given by epi by medics. 20% only got Benadryl and that's it, when every single one of them should have had epinephrine. About 20% of them only got albuterol, and about 1/3 got Benadryl and albuterol. But again, barely more than 10% got the epi that they should have gotten. It's rough, man. EMS providers, we should be doing better. Healthcare providers at all levels tend to withhold epinephrine when it's needed in anaphylaxis. There are no contraindications for epinephrine in anaphylaxis. But I hear you asking, what about somebody who you know has coronary artery disease, right? Like, won't epi possibly give them a heart attack? Well, I'm going to take, yes, you still give epi. Somebody asked do you still give epi even if they self-administered? Follow your local protocols, but if they still have signs and symptoms, we're still giving the epi. Typically, that's the recommendation, but follow your local protocols. I don't want to tell you to keep giving epi if you've got specific protocols that tell you locally it's one and then call, but it's not one and done. They still have symptoms. Epi is still coming. So I'm going to give you the most extreme possibility here when we talk about coronary artery disease. Okay, let's go all the way to the end of the spectrum, something called Kounis syndrome, where anaphylaxis actually causes a heart attack. Kounis syndrome is a heart attack caused by anaphylaxis. So we full on have anaphylaxis and a heart attack. Oh my God, do we give epi, right? They're having a heart attack because of the anaphylaxis. What do we do here? Well, there aren't any consensus guidelines for this situation, this rare, relatively rare situation where we know they're having an acute coronary event with anaphylaxis. Epinephrine could worsen coronary vasospasm and myocardial ischemia. But here's the thing. If they're in anaphylaxis, the anaphylaxis can cause coronary vasospasm and worsen myocardial ischemia. So what do? Epinephrine is still recommended as the initial treatment of choice. In a recent case series, 25% of the patients with an active heart attack because of the anaphylaxis received epi and nobody died. Right? Like, if you got to make that choice, I tell you, I'm still leaning towards the epi. It doesn't mean I'm freewheeling with the epi, but I look at the patient and I go, well, which is going to be worse for this patient right now? More guidelines on it. Epi's not contraindicated for anaphylaxis, okay? It actually increases coronary artery blood flow because the myocardial contractility. So yes, alpha-1 effects, it can cause the coronary arteries, the epi can cause the coronary arteries to shrink down. But the boost in output of the heart can increase blood flow. That's what they're saying. Say, hey, weigh it. If they don't meet the criteria for anaphylaxis yet that we already talked about, or they're pretty close, but they've got high risk factors, well, make that decision. You're the medical provider, but we still lean towards epi. In this one from ACEP, epi is a life-saving in anaphylaxis. Second-line medications are not. In cardiovascular disease patients, the decision to administer epi for anaphylaxis can be tough, and you need to weigh it. But honestly, you need to weigh it against concerns about potential death from untreated anaphylaxis. Bottom line, there's no absolute contraindication for epi when the patient has anaphylaxis as we defined it. Now, sometimes you come into the situation and you know that your patient has had anaphylactic reactions before. Other times it could be difficult to suss it out from different things. So to improve our ability to deal with these difficult differential diagnostic dilemmas, we've got red flags that we look for. So these are things that can make it harder to identify for you or for the patient to identify that there's been an exposure. So maybe they've got hidden allergens. We don't know that this food was fried in peanut oil, or this was cooked in the same kitchen where they were preparing shellfish. A lot of times spicy foods, people don't realize what kind of foods might be in spicy food that might trigger. Alcohol consumption not only can make it difficult to get a straight story from the patient, but the alcohol itself can increase the body's intake of the triggers. You can have communication issues, especially for people who have English as a second language, or otherwise have difficulty in communicating. And sometimes patients don't recognize and don't call you for quite a while. And then we're kind of behind the 8 ball and it's difficult for us to catch up. Things that can worsen anaphylaxis. So if we're getting, I'll go back for a second. So if we're getting these stories about these, you know, and we're not quite sure where the food came from, there's spicy food, there's alcohol consumptions. These are all red flags I'm picking up that make me lean more towards anaphylaxis. Like maybe I haven't shoved it into the patient's thigh yet, but maybe at this point I'm reaching for the epi. Things that can worsen anaphylaxis that make me move a little faster towards the epinephrine. Patients who are exercising, patients who are standing up, because the way that we describe the cardiovascular effects of anaphylaxis, even just standing can worsen it. Stress, not just because of overall stress, but stress on the body, but it releases hormones that can worsen the anaphylaxis. Likewise, hormone release during menstruation, immune system disruption during infection, and yes, even hiding. I had a rookie on my shift at the fire department. I cooked dinner one night that was delicious chicken over a bed of Thai rice with spinach and a Thai peanut sauce. I didn't know he was allergic to peanuts. He looked at the sauce and for some reason thought it was Caesar salad dressing. I don't know. The kid was uncultured anyway. I'm just saying. About an hour after dinner, my lieutenant comes in and says, "Hey, Rob, can I have the keys to the med cabinet?" And I'm thinking, we haven't had an EMS call in a little while. Why do you need the keys to the med cabinet, Mike, all of a sudden? You're not the kind of guy who decides he's going to restock the ambulance at 10 p.m. all by himself. So I go into the EMS closet where I find my rookie so embarrassed that he was swollen up. The kid looked like the Elephant Man. His entire face was all swollen up. He had walked across the street to the local pharmacy to get Benadryl and now had knocked himself out with Benadryl and his face was all swollen up. I was like, oh my God, I had no idea that this had been going on for an hour because my rookie was hiding in the closet. People get so embarrassed by this sometimes. Things that you may not realize can literally worsen anaphylaxis. Well, the same chemicals that are involved in asthma and allergic rhinitis and atopic eczema. So a history of any of these should make you say, hey, that's a big red flag that if I think anaphylaxis is happening here, this could progress quickly and become severe, even if it has not. So GI side, we'll get back to that. I see B31NA. I see your question. We'll get back to it. Asthma, allergic rhinitis, atopic eczema. And for reasons that we don't understand the relationship, but we know that there is a relationship. Patients who have psychiatric illness or PTSD, that can worsen anaphylaxis. And we don't understand what the connection is, but any of these can make it worse. Red flags for special population. Little kids can't explain what's happening. And like little kids do, they compensate, and then they crash. Adolescents, even ones who know that they get anaphylaxis, they experiment with things. These kids are at the age where they break rules. They don't avoid the triggers that cause anaphylaxis, and they sometimes don't carry the EpiPen. Elderly patients who may get anaphylaxis have increased comorbidities, all these other problems that come with them, and they don't have the ability to compensate. Pregnant patients desaturate very, very quickly, but a good thing is that left uterine displacement helps a lot. So patient lays down, the pregnant patient lays down, and we displace the uterus off the vena cava to allow more blood flow back to the heart. Can make a big difference. Red flag medications include beta blockers, ACE inhibitors, and beta blockers a lot, and ACE inhibitors to a degree can block the ability of epi to work. MAO inhibitors can cause the patient to become incredibly hypertensive, or with Benadryl, hypotensive. And NSAIDs, the way that they work with the inflammatory, they suppress the inflammatory response. They can trigger or complicate anaphylaxis. So if they're on NSAIDs to reduce inflammation, that can wind up really causing issues. Check these red flags. Use factors found in your assessment to rule anaphylaxis in. Don't use missing factors to rule anaphylaxis out. Now, here's an example of management profile for anaphylaxis. We're always looking at our ABCs. We want to identify anaphylaxis. And then if we've got anaphylaxis through the definitions we already talked about, we give our epi, right? Typically 0.3 milligrams for an adult. That's a regular EpiPen. 0.15 milligrams for a child under 50 or 55 pounds. If you can, separate the patient and the trigger if reasonable, okay? So if they've got food on them that we think might have triggered it, let's make sure we're still giving the epi first. Let's wipe the food off, get that stuff off them. Let's lay them down until they're comfortable. If we can elevate their legs, give supportive O2 until their SAT is above 94 to 98%. And if it's appropriate for our level of profession, we can give them fluid resuscitation, 5 to 10 milliliters of per kilogram typically. It doesn't always have to be an auto injector, but there are a lot of auto injectors that are out there. This is what they look like on the inside. Please remember that every single one of them, man, they have big and powerful springs. You've got to watch out. But whether you're giving it from a check and inject kit, or you're a paramedic drawing up an IM injection, or you're giving any of these or other types of auto injectors, we give it in the thigh, not the shoulder, not elsewhere. The thigh is the place to go. If you have time to get their pants off or cut open and exposed directly to the skin, do that. Hey man, it's winter in New England. Sometimes we got to do that auto injector directly through some clothes because you're not going to necessarily be able to cut it off fast enough. It'll work, but inject right mid-thigh, mid-lateral thigh. Our primary medication, epi, epi, epi. Sometimes when we give the epi, they get pale, they get anxious, they have a tremor. It can cause headache and dizziness. It can even cause ventricular arrhythmias, hypertension, and it can precipitate acute coronary syndromes. You give the epi for the anaphylaxis and it could cause them to start having angina or worse. Yes, but we can deal with that, and then we deal with that as it goes. Secondary BLS medications are, hey man, if they don't have enough, if their oxygenation isn't what it should be, we bring them up to at least 94% or higher. ALS medications that go with it after the epi, inhaled bronchodilators, again, helps open up the lungs if that's what they need. Can still cause some tachycardia. Supportive fluids, like we talked about. I gave you my protocols right there. Follow your own local protocols and medical direction. Tertiary, third line, we've got these H1 blockers like Benadryl. Okay, it's common, I recognize it, but everybody wants to give Benadryl for anaphylaxis. It's not, well, I mean, it's a little bit, so I'll give you a little Benadryl. It's a terrible medication. It causes hypotension. It's got a ton of side effects. There are much better blockers out there, including clemistine, loratadine, just much, much better. It's not an initial therapy. In fact, American College of Emergency Physicians recently wrote an update, The Death of Benadryl. And if you want more information, you can scan that QR code right there with your phone if you like. There's going to be more information on that at the end. We talked about steroids a couple of times. Okay, steroids like methylprednisolone, 125 milligrams in adults, 1 to 2 milligrams per kilogram in peds. Theoretically, it can help biphasic anaphylaxis, but there are no studies that I'm aware of anywhere that shows that improves outcomes. So would I give it? if the anaphylaxis was bad, I'd probably give it third line, but not first line. First line is epi. Biphasic anaphylaxis, since we're talking about it, usually recurs within 1 to 3 days, typically within 12 hours. The good news is that it usually is uncomfortable, but not too bad, and it's dealt with pretty easily. The outcome for EMS is, even if the anaphylaxis is resolved and then a patient doesn't want to go to the hospital, they should still probably go to the hospital, especially if they received epi. Sometimes, especially because of beta blockers, the anaphylaxis is refractory to our initial epi. Then we may try other vasopressors, including vasopressin or norepinephrine. It's usually block 2 as well. Other vasopressors that you might have. Glucagon increases both the speed and force of contractions through completely different mechanism than epi does. And although it's not one that's typically given by EMS, methylene blue is a medication that's sometimes given in the ER. It's a selective nitric oxide GMP inhibitor. Remember I told you nitric oxide opens up the blood vessels. Well, methylene blue can inhibit that. If things get worse, we may be moving to advanced airway, even cricothyrotomy, and in some emergency departments, they may move the patient to a heart-lung machine or extracorporeal membrane oxygenation, ECMO, to keep them alive while we resolve the anaphylaxis. Hey man, sometimes you use the regular plunger, sometimes you got to break out the big guns. At the hospital, they're going to do all of the stuff that we already talked about. It was in our first case study, right? The doctor was like, hey, you guys already did everything that we're going to do. You didn't leave anything for me. The patient's going to be there for 4 to 8 hours, so we can make sure it doesn't come back around, maybe treat them a little bit more. And they're going to bring them in so that they can have long-term management for later on. So I hope we've answered some of these questions, like what is anaphylaxis? We gave you your 3 definitions that I'm going to skip back to one more time. So known exposure plus cardiovascular is anaphylaxis. Suspected exposure and symptoms is anaphylaxis. So if your patient has GI signs and a rash and has stable vital signs, would you still give epi? Yes, if I suspected that they had an exposure and they had a rash and GI issues, that's suspected exposure and symptoms, they're getting epinephrine. Yes is the answer to that question. And then finally, even if I don't know anything about what might have triggered it, skin signs plus respiratory or cardiovascular issues equals anaphylaxis. I appreciate the questions that you have, and I'm going to give you an opportunity, if you can, to type in some of your questions, but I want to end with failure to use epi or to use it promptly is considered an important and unavoidable factor. Excuse me, an important and avoidable factor in fatal reactions. I want to answer any of your questions, and hopefully this presentation has answered some of your questions already about what we could do better for anaphylaxis. And if there's anything I can do for you other than that, here's my contact information. And yeah, that's it. I appreciate you spending some time with me talking about this important part of what we do together.
Rami, thank you so much for your time this evening and sharing this information. We've placed the session evaluation link in the chat box. We'll open it up for some questions for those that would like to remain on.
Hooray, I hear virtual clapping, but I'm still here for any questions. Why not shoulder is a good one. It's difficult to say exactly why it isn't absorbed as well through the deltoid. I could make some guesses, but it would be supposition. What I can tell you is just that We know that it's been tested as to how quickly the epinephrine is absorbed in different injection sites, including the deltoid or right up on the shoulder, and it's absorbed much more quickly in the thigh. My guess, and it's just a guess, is that you've got much larger blood vessels perfusing your thigh, right? You got your femoral, all the femoral circulation right there. But I don't know that for sure. All I know is thigh injection, much faster absorption. Could you show 3 more detailed slides again? Yeah, absolutely. Absolutely. I will absolutely kick back to those, the detailed slides. Feel free to take a picture of the screen. I'm happy to share the slides with you too. If you want to email me at romduck@gmail.com, romduck@gmail.com, or like I say, you can just, if you forget that, just Google my name. And I'm happy to share this stuff with you. So exposure to a known trigger and reduced blood pressure or organ dysfunction. Likely exposure to a trigger and any of those signs and symptoms. Or sudden skin signs like hives or rash, like you saw in the little girl, along with cardiovascular or respiratory. That's anaphylaxis. We're not asking questions yet about what caused it. We're diving right in and we're getting our epi. Now, we're still going to try and figure that out. We're going to try and gather some of that information, but we don't want to waste time asking more questions when we already got enough information to tell us epi is needed now. Exposure and cardiovascular, anaphylaxis. Suspected exposure and symptoms, anaphylaxis gets epi. Skin signs and respiratory or cardiovascular, anaphylaxis, because we want to stay ahead of that anaphylaxis. I will tell you. I'll give you the easiest email that I have. If I knew that they were on a beta blocker, I would still go with epi first. I hate to say this, but I don't have your I don't have the different protocols handy. I am looking for, where is it? It is typically one. Refractory there. Yeah, there we go. 1 to 5 milligrams for adults, up to 1 milligrams in pediatrics. So it really depends on your local protocols. That's why I was looking for that one. Yeah, the glucagon, I've seen it as low as give 1. In my department, we carry 5, and everybody's like, glucagon's expensive. Why do we carry so much? Because I want them to be able to have it in those cases. Exposure to poison florals. They stick around for days. Okay, that's a good question. Okay, so in that case, they've got the skin signs, but I got to tell you, if they had skin signs and symptoms, and even if they were saying to me, yeah, look, I think it's poison ivy, but they had difficulty breathing along with that, if I'm seeing skin signs that are not localized, okay? So in other words, if they get poison florals like ivy, oak, sumac, etc. Yeah, oh, there you go. And I would look, is it isolated to that area? If it's popping up in other places where they were not exposed and they are suddenly having difficulty breathing or extremely elevated heart rate to keep their blood pressure up, or a drop in blood pressure, or a drop in urine output and things like that, then yeah, I would still give epi. But I wouldn't give epi just for somebody who said, well, you know, I've got really bad poison sumac over here. That's a different thing. Yeah, beta, remember I said that epi was, so I indicated that epi doesn't work in some cases. I indicated in beta blockers, right? that. Yeah, well, no, actually, we're still here. I'd be better off staying here. So some blood pressure medications and medications that people take after heart attack are called beta blockers, and they block the body's response to really boost up the work of the heart. Because if after somebody's had a heart attack or they're trying to keep their blood pressure down, you don't want their heart to really get that boost and work extra hard. The harder the heart works, the more oxygen demand it has. So we're trying to keep that down. So those people are on beta blockers. Remember I said beta made bigger. Okay. If they're on those medications, it can block the beta effects that epi uses to open up the lungs, make the heart beat harder, and block those chemicals that are sort of that domino effect. Again, I would still give epi first. But if that epi looked like it wasn't working in 3 to 5 minutes, I, as a paramedic in Connecticut, am moving on to glucagon, and I'm going to give them an intramuscular injection of glucagon, because that's going to help do some of the same beta effects, but not through beta, right? So the beta blocker is not going to block it. The glucagon kind of does an end run around it. I hope that clarifies. Still going to try the epi, even if they just say they're on beta blockers, but I'm probably going to be ready and go, okay, but if the epi doesn't work, I'm already drawn up and getting the glucagon ready.
Rami, there was one other question. Laura Mayer had posted protocols say Solumedrol as well. Is that better than Benadryl?
They're for different things. The big thing with the Solumedrol, with any of the corticosteroids, is that they're trying to prevent it from the biphasic anaphylaxis. It's theoretical is the problem. Like, a lot of people do it, and I wouldn't tell you to not do it, but we don't have any research that I was able to find anywhere that says people who are given Solumedrol have better outcomes. Like, I couldn't find anything. So I wouldn't tell you don't give it if it's in the protocols, merely don't make it a super high priority. Again, it's the epi thing. Like, I've seen people go, well, this is really bad, so I'm going to get that Solumedrol on board as soon as, let's get some Benadryl and some Solumedrol on. But like, they have anaphylaxis. Give them the medication that we know is going to work. Epi. If down the road you want to give them Solumedrol a little bit later on, yeah, sure, why not? It may even help resolve symptoms a little bit. It may make them feel a little bit better. It may sometimes it helps with the make them a little bit more comfortable with their skin. But it's not going to improve their chance for surviving anaphylaxis. It's not that high of a priority. And thank you, I had missed that one.
And just a reminder, please be sure to complete the evaluation, whether or not you're going to be requesting continuing ed credit. We do remove your contact information, but the evaluation portion will be forwarded to our presenter, and it's very useful.
That's true. If you liked it, I'd like to know what you liked. If there were parts of it you think we could do better, I'd like to know that too.
And if there are no additional questions, we'll go ahead and close out the session for all. And Rami, again, thank you so much for your participation this evening.
Absolutely. Thank you very much. And hey, everybody, stay warm, stay safe.